I can't follow that, so I'm not going to be jovial and gregarious. I'm just going to put on the face that, I joined Crossroads because it's the opportunity to reshape healthcare and to think differently. And it's a whiteboard with people who are as goofy and crazy and passionate as Ihrig. Where are we today? My role has been to look at this problem and say, how do we create new service lines in an ever-changing environment? How do we make them sustainable financially? How do we improve provider satisfaction and always being as patient-centric as possible? Okay, so what I'd like to just share for a few minutes is how we are moving forward to operationalize all of this. All right, so I joined about a year and a half ago after the big move of a large percentage of the Crossroads patients to a palliative paradigm. And it gave us the opportunity to dive deep and understand what's happened to those people within the system of medicine and within the organization of Crossroads. Good, bad, or indifferent. Certainly they're still receiving care, second to none, because that's what we do. But does it work? Right? Let's look at the model, and that's what I want to talk to you today about, and some of the inexorable challenges that we're facing. So I want to talk to you about upstream opportunities. What is palliative care? A lot of the business development people in here have said we are hospice and palliative care, right? There's no model that's been defined that's a successful true palliative care model. I was successful in a Pioneer ACO. I was the only variable. I scaled myself. I was available 24 hours a day, 7 days a week for 4 years, and had the opportunity to prove what's possible. Again, with 95% zero admissions, or zero hospitalizations, highest satisfaction rate across the country, not limited to palliative care, but any service line. Decreased 30-day readmits from 40 to 3%. Decreased hospital length of stay from 4.75 to 2.1. Anybody that was on our service? At the end of the time, I was first provider, and upwards of 8 to 10% of anybody who rolled into the emergency department. Okay, how do we scale that? By the way, right? We paid for ourselves. We were economically neutral. We didn't lose money. And per capita expenditure reduction across 4 years, all diagnoses, all ages, 70%. 70. I shared with you yesterday the aggregate Medicare shared savings across all ACOs in 2017 was 1.25%. So we're trying to scale that and replicate that. We have 11 sites of service, and this is how we're going about doing it. Our big initiative 2019 is a palliative care transformation initiative. So we had to unpeel where we came from and understand where we were at and how do we accelerate change to get to where we want to be. Looking at upstream opportunities, system perspectives, really looking at ourselves in the mirror and saying what works, what doesn't work, what do we know, what do we don't know, what's the difference between the two, right? And it's some hard questions, and it's been some tough times and some tough realization of what has come before. A hospice model does not work upstream. It does not. The variability, just from a clinical perspective, exponentially increases. So this circumscribed model of hospice, which we're all second to none at delivering, does not work upstream. We've proven that. If I could share to the tune of at least 6 zeros annually, times 4 and 5. Okay?
Now let's get a little personal. I'm gonna give myself just for thinking a cuss word.
But in the setting of what we have avoided, right, it has more than paid for itself. But to move forward, right, it's just not sustainable. And so that's what we're collectively working on. So it's understanding our own system and how we utilize the resources that exist within the system to create change. And so we're going to share some lessons learned as well. I'm just going to touch on this, but we are available, right? To Greg's point, to the point of the Q&A, right? How do we affect change? You know, with all due respect, yes, a repository for staying connected is important, right? But how do we accelerate change? From an advocacy perspective, and all of you that want to move upstream in community-based palliative care or have engagement with hospitals, let's learn together. The greatest thing I can offer right now is there's 100 mistakes you can make, and I've made them all right? And so let's learn together, and that means a collective, ongoing commitment to each other to accelerate change, holding each other accountable and responsible. If I gave you all a magic wand and said, create the ideal program, okay, how do we get there? How do we look at the resources we have and make it happen? 11 sites of service. Kansas City is our largest, 25th largest hospice and palliative care standalone in the country. So we're doing a majority of our heavy lifting. It's a co-production. It's bringing everybody in within the palliative care and saying, what are the opportunities? What are the challenges? What makes you happy? What does not make you happy? And let's break it down and let's use the data to influence where we move first. And the success is not necessarily in the outcome. The success is that we are co-producing and we have a relationship with all the people at each site who are helping inform that change. So they have ownership. We talked about millennials. What brings meaning to you? Look, they're creating this as well. And so it's a heavy lift. There's a lot yet to be done, but we are doing the work to create a model. And we are here to share that with all of you and learn from and grow collectively. Okay, so that opportunity exists. Don't let it pass you by. Because what's at stake is what Perry has experienced, and all our heads are on the chopping block. Okay? So again, look at upstream opportunities. We have a big challenge, and we have a lot of hard work to do. But let's learn from each other. And again, the key is to accelerate growth and change. Accelerate that change. We have to look at our own systems, right? It used to be, we've lost X million dollars by creating a palliative care program, right? But then we reframed it and said, it saved us from losing the organization. Okay? Two different perspectives, same number. So we need to look at what we're doing differently so we can come up with different approaches to move forward. What already exists within your organization? Allocation of resources, etc. And having the courage, you got a 15 to 20% growth rate annually over 20 years, developing and delivering hospice. It's working great. The assumption is move it upstream and we're fine. The realization is it doesn't work, and that's a tough pill to swallow. So have the courage to really look at it and recognize what works and what doesn't work and be open to affecting change. System perspective, right? The way we look at ourselves is different than the way the system of healthcare looks at us. On the heels of philosophically what I shared yesterday, why we need to think differently, go from a Rembrandtian perspective to a Pollock perspective, understand the value proposition that we provide and can deliver in the big system of healthcare is very different than the way the system looks at us. Again, the system doesn't care about us. Again, the system doesn't care about patients. Right? They have no mechanism to care for patients. We need to bring that forward. System perspectives, even within our own system, right? We have to challenge our own assumptions, and one of the greatest challenges I'm finding is managing expectations and personalities within our own organization, and this is not a value judgment on any individual. They're wonderful and they want to care, but they know what they know and they don't necessarily know what they don't know. And to challenge them and say, I'm going to seek advice and support, and I want you along this journey to co-produce to change. It's not for everyone in the organization. So we have to find those champions and those leaders, right? And like Greg said, there's managing and there's leading, and it's very, very different. And it takes time. Right? And it is a couple steps forward, a step back. But it does have to start today. So some may not want to change. And that's okay. And that's okay. Let's tether ourselves. I think we're all here because we want to change. We may be scared. There may be instances where we've tried and we've failed. I'd say it's not a failure. It's a learning opportunity. And rapid cycle change, that's a part of it. You have to understand your organization's appetite for change. What is the rate of change? We specifically have a lead medical director in our Kansas City office who has a voracious appetite for change and leadership that's allowing us to do that. And so it can be very invigorating and fun. But you have to be mindful of all the moving parts. So what are the lessons learned, right? I touched on this yesterday. We can't solve the problems that have come with the same thinking that created them. It just doesn't happen. There's safety in numbers, in being a collective, in the aggregate experience and knowledge and belief in ourselves is what's going to drive this change. So my call to arms, right? I'm going to have my dear friend and colleague, Greg, chime in if he so chooses. It's not wait until next year. It's today. If you're interested in this, let's get the information together and let's do the work. Because nobody else is going to do it. And to my good friend and colleague, Perry Farmer, right? This is bi-directional. There's enough work to be done. There's enough damn work to be done. Right? That we're not competitors. We can worry about stabbing each other in the back and, well, this is my patient, that's your patient. We're going to get nowhere. We have to bring this forward collectively. And my favorite saying is, the electric light was not invented through the improvement of candles. We got to stop playing in wax, ladies and gentlemen. I'd like a show of hands of people who are sincerely interested and would like to continue this conversation, not just at the conversational level, but engagement and rapid cycle change to accelerate change within our industry, horizontally and vertically. It starts today. And if you're interested, raise your hand, because we're all on board and let's do it. Fantastic. It doesn't stop when we leave. It starts when we leave. And so let's make sure that is started. I'm going to give the conch to Mr. Kotzbauer for 1 second, because this is what he does, right? This is why I'm so honored to be his friend and to collaborate with him. What would the next step be, Greg? $100 from each person?
No selling.
That accelerates. That's not selling. They're buying.